Good evening, everyone. We will be starting our presentation now. And my name is Dr. Amar Swani, and I am a consultant physician and nephrologist working with the Shree Mandal Hospital in Dar es Salaam, Tanzania. And it is my utmost pleasure to introduce to you our presenter for tonight. His name is Professor Kaushik Ramaiya, and he is the Chief Executive Officer, Consultant Physician, and Diabetologist working with the Shree Hindu Mandal Hospital in Dar es Salaam, Tanzania. He is also the Honorary Lecturer and at the Department of Internal Medicine at the Muhimbili University of Health and Allied Sciences in Dar es Salaam, and also the Honorary Professor of Medicine and Global Health in the Liverpool School of Tropical Medicine in the United Kingdom. Professor Kaushik Ramaiya is a member of the board of the World Diabetes Foundation and the Honorary General Secretary of the Tanzania Diabetes Association and the Tanzania NCD Alliance, and also the President-elect for the East African NCD Alliance and a member of the board of Global NCD Alliance. Professor Ramaiya has served as chair of Sub-Saharan Africa region of International Diabetes Federation from the year 2000 to 2006, and then as the vice president of the global of the IDF from the year 2017 to 2012. Professor Ramaiya did his schooling in Dar es Salaam and then received his basic medical training at the University of Bombay in India in 1981 and completed his postgraduate training in internal medicine at the University of Dar es Salaam from 1986 to 1989. His postmaster's training was in the University of Newcastle in Upperton, United Kingdom from 1990 to 1991. And then he was appointed the Honorary Professor of Medicine and Global Health at the Liverpool School of Tropical Medicine in November 2018. Professor Ramaiya has greatly contributed to a better understanding of diabetes in the African region, and he has also investigated on the status of diabetes care in Africa and the economic costs of diabetes and its consequences. At present, in addition to being the CEO and consultant physician at the Shree Hindu Mandal Hospital, Professor Ramaiya is working with the children who have type 1 diabetes, women with gestational diabetes, metabolic syndrome, and cardiovascular complications of antiretroviral drugs in HIV/AIDS and diabetes-TB interaction. Together with the National Institute for Medical Research, Muhimbili, and the London School of Tropical Medicine, he is working on the communicable and non-communicable integration models, which is also known as the MUHAS study, the management of chronic conditions in Africa. And he will be overseeing the metformin intervention in HIV patients with impaired glucose tolerance, which is the META trial. He has also participated actively with other colleagues in the Tanzania Diabetes Association, the Ministry of Health, and the President's Office, Regional Administration, and local government to implement diabetes NCD program in the zonal, regional, and district hospitals all over the country. This program has also now obtained additional funding to expand and encompass the NCD prevention and promotion and curative services in primary care, training, policy, and legislations, and monitoring and evaluation and operational research. Professor Kaushik, it is very kind of you to take time out of your busy schedule to be with us this evening, and we would love to hear your talk on the challenges and the future of diabetic complications in Africa and what the evidence suggests. So thank you very much, and a very welcome.
Thank you. Thank you very much, Dr. Swali, for the introduction, and thank you to HN for giving me this opportunity to talk. The topic I was given by Dr. Lloyd was the challenges and future of diabetes complications in Africa, and what does the evidence say? Unfortunately, in the African region, the evidence is now gathering pace, but the basic evidence to say that how are you going to prevent the future complications is very scarce. So what I'm going to do is I'm just going to review some of the literature, but most important, I'm going to talk on what is the way forward and how can we move forward when we're talking about complications in Africa and how can we prevent these complications. So my introduction is basically the slide which is showing evolution of type 2 diabetes, its risk factors and complications. And if you look at this slide with the diagnosis of type 2 diabetes, there are comorbidities which are usually hypertension, albuminuria, dyslipidemia, and uncontrolled hyperglycemia. This results into cardiovascular complications and chronic kidney diseases. There's an evolution which results into heart failure for CVDs and terminal kidney failure for the CKD, resulting into the premature death. If you look at the time span which is spent from evolution from the type of diagnosis till the premature death varies from country to country. And in the sub-Saharan African region, on an average, for every single person diagnosed with diabetes, there are 2 or 3 out into the community who do not know that they have diabetes, and they normally come to the health sector for health facility with a complication, one of the 2 complications which are there. So the duration of complication varies quite significantly. What are the consequences of this vascular disease? And if you see, when you have hypoglycemia, the eye complications are usually retinopathy, diabetic macular edema, resulting into blindness. Renal is albuminuria, reduced EGFR, end-stage renal, progressive end-stage renal diseases. When you look at the nerves, it is mainly the foot ulcers and peripheral neuropathy, together with sudden deaths in some of the patients. When you look at the heart, it is mainly angina, cardiac failure, congestive cardiac failure, myocardial infarction, and stroke. With the brain, you have progressive dementia. With the blood vessels and the blood supply, you have high blood pressure, significantly systolic blood pressure, sudden death, and peripheral arterial disease. And with bone marrow, you have reduced endothelial progenitor cells, resulting into impaired vascular healing. So the major issue here is hypoglycemia. And with this hypoglycemia, if you find, which I'm going to show subsequently, what are the challenges, the resultant complications which we get within people with diabetes is resultant into the uncontrolled diabetes. So currently, if you look at the cardiovascular risk, which is the major topic currently, you find that in addition to lipids, hypertension, diabetes also becomes one of the basic underlying cause of the risk factors in the cardiovascular diseases. Once again, if you see in most of the clinics in our settings whereby hypertension is much more predominant, the prevalence of hypertension in the African region varies anywhere from 24% to 36%, depending on which country are you talking about. And when you talk about diabetes, the range and the spectrum is anywhere from 4% to around 12 to 14%. And you see that there is a huge interaction between diabetes and hypertension predisposing to the cardiovascular risk factors and the cardiovascular diseases. Most important is atherosclerosis, endothelial dysfunction, vascular inflammation, vascular fibrosis, and arterial remodeling, resulting into macro and microvascular diseases. People with diabetes are at increased risk of cardiovascular disease. Mainly, it doubles the risk of the vascular disease, and cardiovascular disease affects 32% of all the people with type 2 diabetes, and it accounts for 50% more deaths resulting in people with diabetes. Again, if you look at the life expectancy, this is a global data, but if you look at it, if you contextualize within the African region, you find that basically vascular deaths and the non-vascular deaths, again, within this component, you find that there's a premature death which occurs at a much early age. This is another issue which is coming to the forefront within the African region, is the pregnancy and unfolding pandemic of the NCDs together with diabetes, hypertension, and other non-communicable disease. And as we know that nutrient-mediated within the component of undernutrition and overnutrition, you have obesity, gestational hypoglycemia, IGT, diabetes, cardiovascular disease, and you've got also an environmental exposure, which is predisposing to this multimorbidity in diabetes. Now, what is the current burden? If you look at the IDF Atlas, and if you look at the burden of diabetes in sub-Saharan Africa, 1 in 22 adults have diabetes, which is 24 million, and it is expected that the incidence and the prevalence, actually the incidence of diabetes in the African region will reach the highest from the low middle income countries. The total number of people with diabetes is predicted to increase by 129% to 55 million by 2045. 1 in 5 persons living with diabetes in region are undiagnosed, and hypertension, and basically this is the highest from the IDF regions, which are the low and middle income countries. Diabetes is responsible for 500,000 deaths in 2021. It has got the lowest diabetes-related expenditure when you compare to the other countries and other regions in the world. 1 in 8 live births are affected by hypoglycemia in pregnancy, and there's a late presentation, as I mentioned. Most of these patients with diabetes come to the health facility with a complication rather than an early diagnosis, and they have life-threatening and disabling complications. And this is again the region, sub-Saharan African region. And if you look at the prevalence varies from anywhere from less than 5% to more than 7%. But it's usually see that in Southern Africa and Southeast Africa, together with East Africa, the burden is quite high. Recent surveys looked at the STEP survey, which have been usually the WHO mode of looking at the prevalence of this non-communicable disease, but at the same time, looking at the underlying risk factors. And if you look at the African region, whereby you find that, of the 33 countries in the WHO African region who have conducted stepwise surveys, and you find that of these surveys, this is just a summary table of the risk factors which are there, which are comorbidity and coexisting with the diabetes. And if you see tobacco smoking, alcohol, fruit consumption, physical inactivity, it varies. For example, physical inactivity in West African countries like Mauritania, Cameroon is more than 40 to 50%. In Algeria, it's around 40%. Alcohol drinking, 87% in Seychelles. Again, heavy episodic drinking, 60 to 66% in Chad, and prevalence of tobacco is also high. Again, if you look at overweight and obesity, you find that overweight and obesity varies from 22 to 42% overweight, and obesity varies from anywhere from 5% to 25%. Hypertension, as I mentioned, anywhere from 25 to 35%, pre-diabetes and diabetes around 8 to 12%, and dyslipidemia more than 39%. Again, if you look at the stratified prevalence of diabetes and obesity among the 12 countries of sub-Saharan Africa, this is a literature from the Lancet Commission, and you find that there is a huge variation in obesity levels, and especially females are more obese than male, and this has got quite a significant contribution towards the comorbidities which you see with diabetes. What have been the major challenges? Major challenges that there are usually in this sub-Saharan Africa, there's been a huge backlog of major infectious disease. Diabetes is still not a public health priority. There's insufficient epidemiological data. There are high proportion of undiagnosed cases. Many persons with type 1 diabetes are not treated or inadequately managed, and there's a high prevalence of complications. The health system, health infrastructure is very poor. There's a lack of qualified and trained staff. There's quite a huge staff attrition. Even when you train them, the staff attrition is high. There are supply and logistic challenges, and there's a lack of funding and prioritization of the non-communicable disease. This is the reason why we see a huge burden of complications of diabetes. This is again from the Lancet Commission, and if you look at this data, which is there, you have 100% total people with diabetes, only 50% have their glucose measured, only 37% of them are aware of the diagnosis. Out of this, only 17% receive advice, while at the end of the day, only 11% receive the medication. And of those 11% who receive the medication, more than around 86 to 90% are poorly controlled. Only less than 10% are adequately controlled. And as I mentioned in my introductory slides, hyperglycemia, if your blood glucose is poorly controlled, it is resulting into huge amount of complications. So what is our basic approach here? The basic approach is get these patients, if they are diagnosed within the community, early on, get them to the health system, get them measured, make sure that you get them controlled much, much earlier rather than coming to the health facility with the complication. The other challenge is the workforce. And if you look at this slide, it will show you that basically the workforce, the global burden of disease is more than significantly higher in the African region. But if you look at the workforce, it's less than 5%. So when you compare to the global burden of disease, which is more than 25%, but less than 5% of the global workforce is available for managing more than 25% of global burden of the disease. Again, if you look at other challenges, affordability of the drugs, why are our patients not well controlled? Main reason has been the economic, and you find first is the diagnosis, 2 is awareness, 3 is managing this patient very well. And if you find that if you are able to diagnose them and manage them, then is the cost control. So if you look at this comparison here between Ethiopia, Kenya, Nigeria, and Tanzania, and if you look at the basic supply of the drugs of glibenclamide and 500 milligram of metformin with 5 milligram of glibenclamide as a primary drug, and you see the number of days of wages to pay for this drug for the month supply. It varies from anywhere from about 4 to 7%, 7 days of monthly wages, which makes them to be spending on buying of these 2 drugs. And that out-of-pocket expenditure is a major challenge. The second factors which influence these factors are type and stage at which the diagnosis is made and what are the comorbidities there. Once you have the diagnosis, then the question is, how do you finance these complications and ability to pay? How much can they pay out of pocket? Do they have an access to the healthcare facility which can provide them comprehensive care? Or do they need to move from primary to secondary to tertiary? Again, there's a gender bias in the sense that you find more of the mothers coming to the more of the female patients coming to the clinic much earlier than the male, because they are main nucleus of the family and they would like to be well to manage the family. And you find that there is a gender differences in access to the health facility. Again, quality of health system, because of the different levels of healthcare, there is a quality issue. And then you have awareness and willing to participate in the self-care. Challenges which are faced by the households with diabetes are also mainly poverty, as I mentioned, poor education, lack of information, lack of awareness, perception of health, traditional medicine, traditional healers, again, personal involvement, and again, a certain degree of mental health issues due to depression or the chronic disease. Again, you have dependency on other complications, because normally when the diabetes starts, there are hardly any symptoms, and you find that unless there is a complication, that is where suddenly they become aware. As we mentioned, what are the consequences of a poorly blood glucose control? Again, you have morbidity, high morbidity, and premature mortality. The macrovascular complication, ischemic heart disease, stroke, and peripheral vascular disease, retinopathy, nephropathy, and neuropathy. And again, with the disease-related, patient-related, and system-related, which I already mentioned, but this is a summary slide which shows what are the different components of care which we need to be careful about when we are managing these chronic diseases. So how do we respond within limited resources, limited human resources for health, limited financial resources, limited awareness? How do we basically respond to the rising diabetes burden in sub-Saharan Africa, in addition to the hyperglycemia and the complications and the comorbidities? First, as we said, it is less urgent for managing diabetes than the competing interests of the infectious disease. Again, the NCD as a program has had its limitations, but now, because of increasing burden, ministries are becoming aware, and you find that the health systems are not geared to manage the chronic diseases. So what is our main trump card in the African region? It is preventing diabetes. How do we prevent? First of all, diabetes from occurring? Two, how do we prevent those who have been diagnosed early, to manage them so that they have a good blood glucose control? And what we need to do is to manage these complications much earlier. We need to manage early diagnosis, early comorbidity diagnosis, and making sure that we do not basically lead these patients or these clients into a poverty cycle. So what is the way forward? One, we need to address prevention, early diagnosis of diabetes and its complication, providing reasonably good care which is feasible, cost-effective, and cost-saving. Providing no care and ignoring diabetes may save health costs, but will have a significant impact on productivity and result in indirect costs. Supporting sustainable education programs within the existing health system, which is feasible, creates advocacy, and strengthens the health system. How do we prevent diabetes? One, we look at the modifiable risk factors: abdominal obesity and generalized overweight, physical inactivity, and increased total dietary fat. And as we have mentioned previously, obesity and overweight is becoming the major driver of this diabetes epidemic in the African region. Of course, we have got non-modifiable risk factors, which we can't manage much, but obesity is the single most important factor which we need to do to prevent diabetes. How do we target those for diabetes prevention? We need to have those with high-risk individuals and entire population. What is preferable? High-risk individuals identify by brief screening questions. There have been diabetes risk scores which have been developed as a triaging so that you ensure that you can manage, because testing of the blood glucose is also a cost. Managing HbA1c is also a huge cost. So you need to do some sort of a triaging to ensure that you are picking up those individuals who feel at a high risk. Again, healthcare professionals need to be educated on identifying those at risk and making sure that we make a correct diagnosis. Criteria to identify individuals at a high risk are mainly central obesity, measuring the waist circumference, finding out family history of diabetes, whether there's a first-degree relative, parents or sibling, age more than 35 years in low and middle-income countries, whether there's an underlying cardiovascular history, which includes high blood pressure or cardiac disease, whether there has been a history of gestational diabetes, and again, looking at the drug history, what other medications are being taken by this individual. What would be the major barriers in identifying these high-risk individuals? One is mainly resulting into these screening questionnaires, whether they have been validated or not. There have been few countries in the African region who have validated risk score questionnaires, which are available, but there is no definitive national policies to do screening and prevention of diabetes. Again, when you look at opportunity screening challenging, it is usually you find that time constraint is there, clinics are busy, there is a staff shortage, and there is a poor infrastructure to do this targeted screening. How do we actually overcome these barriers? We need to reorient our healthcare services. We need to basically change the health system at the level of the policy, organization, training, and facilities. We do not require a lot of resources, but what we need is right policies and frameworks in place. We need to do task shifting, and this task shifting needs to come at different levels from secondary, primary to tertiary to secondary to primary. We also need to use community health workers at the primary care, but at the same time, use the model of HIV care and TB and try to see how we can actually use home-based care models to do the early screening. We also need to look at the integration. Again, what we have seen from the data available, that patients who have been on antiretroviral for a long time are starting to develop blood glucose, elevated blood glucose, diabetes, and other complications. Whether we can use the integrated clinic approach where the retention is very high, early screening can be done at those clinics, at the integrated clinics, and identify these patients with diabetes and other comorbidities as a more focused approach. Again, if you look at the biochemical testing, availability of the resources of blood glucose testing, HbA1c, OGTT, you need to find out exactly which is going to be the most cost-effective and how are we going to put the protocols in place. We again, within the certain facilities, you find the blood glucose meter would be there, the strip would not be there, or if you find HbA1c, again, it has got its own limitations, and OGTT has a major limitation. Affordability is the major barrier of people having a diagnosis done. Again, as we said, lack of awareness within the community, using mass media to make sure that we do enough community awareness, and then within the semi-urban and rural areas, access to care is a major challenge. Lifestyle intervention is a buzzword, but implementation of a lifestyle intervention is a major challenge. And you find that basically people, the luxuries they have with the lifestyle, and when you ask them to stop those luxuries, it is a major barrier, but repeated exposure to these messages will actually bring about a lot of way in bringing about this lifestyle intervention and changes. Population approach is also very important. And again, here you need policymakers, you need legislations regarding the taxation of the food, healthier foods, soft drinks, and other risk factors, smoking, alcohol, and foods. Again, you need to involve different sectors. And as you know, most of the underlying risk factors for non-communicable disease, more than 80% of them are outside the health sector. You need to get other sectors on board, and multi-sectoral approach is the best approach to go to them. If you look at the African region, what have been the policy actions taken up to now? There has been a WHO strategy on NCD in Africa, adopted in 2000 and updated in 2010. Again, there has been a Brazzaville Declaration on NCD in 2011. There has been a huge multiple regional multi-stakeholder dialogue in 2013. There's been an African health strategy over salt reduction, smoking, which has been in place. The policy documents are there. Again, WHO Afro has come up with a diabetes Afro strategy for prevention and control of diabetes in 2007, which is up for updating now. There's been a strategy for mental health, strategy on harmful use of alcohol, and strategy on cancer. All these policy documents at the regional WHO framework are there. What it needs now is regulations and implementation of these policy frameworks. Again, if you look at diabetes prevention, if we are to prevent diabetes or if we are to prevent the complications, I think what is there, it requires an incentivization. And if you look at incentivization, unfortunately, diabetes prevention has got no incentives for the people, for the health services, for the health industry, for the politicians. So you find that, again, it is a major challenge getting diabetes prevention agenda on board. So what do we feel? This is the model which we are now testing in Tanzania at the primary health care. And what we are saying that at the primary health care, what we need is actually a common triaging all the individuals who come to the health facility should have a general screening of the body mass index, blood pressure, blood glucose level, provided initiative HIV testing, and tuberculosis screening. And based on that screening and based on those triaging, you basically go for the disease-specific services, but at the same time, you go for the specialist clinic. At the same time, this health facility is linked with the community health workers who do the education, screening, and treatment adherence, looking at the health education, also focusing on workplace education programs, school health program, screening camps, and mass media. And that's how you would like to reach the community. This is a model we have started testing in Tanzania at 700 health centers in the country. Some of them have started adopting that, and we are following that up, monitoring and seeing what effect it is going to have on overall after certain years. Again, one of the biggest stimulant currently has been the global targets which have been established and they have been approved by the 75th World Health Assembly in May 2022, which says that by 2030, 80% of the people living with diabetes should be diagnosed, 80% should achieve a glycemic control, 80% should achieve good blood pressure control, 60% of the people with diabetes aged 40 years or over should receive statins, and 100% of the people with type 1 diabetes should have an access to insulin. Whether these goals are going to be achievable or not, but at least now we have a target, just like HIV. And when you have a target, whatever targets you try to achieve, at least it's a success factor which you look at how much do you achieve. And with these global targets, this is what the goal should be. And if you are able to diagnose 80% of people living with diabetes much earlier on, will prevent the complications. And as I say, within the African region, prevention is the key. 80% if we can achieve glycemic control, will automatically prevent the complications. And if we can achieve a good control of blood pressure, diabetes and hypertension is a major contributor to the chronic diseases. We need to actually have an integrated approach to the levels of health system. We need to be closer to the patient, fewer patients per provider so that we can provide a quality care. We need to be focused. We also need to combine with other diseases which require chronic care. And looking at the chronic care model, the best model currently is the HIV model, whereby you find there's a retention in care, there's a good quality of care, and they are achieving, we are talking of 80%, they are talking of 95%, and soon they are going to talk of 100% target. So what you find that we need to learn from what experience has been there. Again, if you look at the management of complications, these are the NCD best buys, which have now been promoted by the WHO, and you find that if you are able to basically have an excellent return on investment, if for every dollar invested for tobacco prevention, you get a return of $7, alcohol for $1, you get a return of $8. For healthy diet, for every dollar invested, you get $11 return. Physical activity, $3. Managing cardiovascular disease, around $3. And HIV and cervical cancer screening, $2. So you can see that if you just focus on diet, alcohol, and tobacco, the rate of return of a single dollar invested is huge. We need to basically, to manage these diseases and complications, we need to look at these pillars of WHO health system. We need to have a governance place. We need to have diabetes and NCD integrated within the health system. We need appropriate health financing model. We need to have an appropriate supply chain in place, health workforce, and a good service delivery, which provides a quality care. So as I mentioned now in a summary, if you look at progression of type 2 diabetes and obesity and unmet needs in diabetes, as we say, you have a progressive, when you have an uncontrolled diabetes, you have beta cell declines, you have a glycemic targets which are harder to reach, there's a weight gain, there's hypoglycemia, you get complications resulting into micro and macrovascular complications. There are drugs which are now there to help to prevent these complications, but these still drugs need to be affordable and need to be accessible for us to manage. So where should our money be spent currently? If we have to look at complications, today we are spending a lot of money in tertiary and secondary care, but future should be that we should be focusing on primary care, primary prevention, less of secondary and much less of tertiary prevention. Thank you very much.
Thank you very much, Professor Kaushik. And this was a very enlightening presentation. Thank you for everything that you do to make this, to overcome this insurmountable mountain that we have in front of us. I'd like to welcome questions. We have the chat box open for everyone to post their question. Panelists can unmute themselves and ask Dr. Kaushik their question. And also, if the attendees would like to ask Dr. Kaushik something, please raise your hand and we will unmute you to ask your question live. In the meantime, I would like to invite Dr. Lloyd for the first comment. Dr. Lloyd.
Thank you very much, Dr. Kaushik. This is an elaborate and extensive presentation, a lot of insights. I was just saying one of the ways by which we can actually tackle the next generation people, providing them with information, I think, is educating the high school kids, teaching them how to monitor blood glucose at home, measuring blood pressures at home. I don't know, what do you think of the idea? School health should be a topic in the school where children are made aware of these things right up front, more than, I think, as equivalent as mathematics and science. What is your view?
I think Dr. Lloyd, what you are mentioning is something which you are now trying to see, because I think at the school, because when we were in school, we used to have at least every week 2 hours of health education classes. And there was health education, but at the same time, physical activity, which has actually moved out currently. It's not being prioritized. And this is what we are trying to do. So our approach, we have started a pilot, and we are actually trying to see how we can create a training curriculum for the teachers, for them to teach the students. That's number one. The second thing which you mentioned, there has been a study from Jordan, whereby what they did was they took the patients who were attending the diabetes clinic, and they gave them a glucometer, and they gave them 100 strips, and they said, go and screen. That empowered the patient, and we call them as peer educators. So we tell them, empower the patients to go and manage and actually check the blood glucose of all the people living around their houses. So they used to take about 10 households, go and screen them. And those who had a high blood glucose, they would be brought to the clinic. And the person who has actually identified this individual would get a bonus extra bottle of a strip, but at the same time, he has brought in this person. And it was a very interesting thing, because it actually brought about a snowball effect onto the community, because now patients with diabetes were going and screening other members of the family in their neighborhood, and that brought about quite a huge return. So it is something which needs to be looked at. But the bottom line here, Dr. Lloyd, is the cost of the blood glucose strips. You see, because that is the major problem. Because if you look at the cost should not be more than, for example, in Tanzanian shillings, should not be more than 300 or 500 shillings. Testing blood glucose costs anywhere from 2,000 to 5,000 shillings. And that is a major challenge. Yeah.
Dr. Yuri from Kenya has a question. Dr. Yuri, can you unmute yourself, please?
Yes, thank you, Professor Kaushik, for the very enlightening presentation. Question, I don't know how possible it might be, especially at a larger scale, to probably also lobby governments in terms of even introducing something like a volumetric tax, especially on soft drinks and foods with a lot of sugar, so that at a larger scale we're able to stem the rising epidemic of obesity. And I think also in terms of consumption of soft drinks and sugary foods, which probably some of the tax might be reinvested back into treatment of diabetes and possibly also in research. I know it might require maybe some of the doctors to also go into politics. I know Africa is a bit murky when it comes to politics, but as if you want to probably be healthcare advocates, maybe it's something that we can also lobby as doctors and see whether at a wider scale it can also help.
Yeah, we, from the Tanzanian experience, what we have managed to do is that we have managed to have there was a parliamentary committee on HIV, AIDS, TB, and substance abuse. And with our advocacy, we have managed to get non-communicable disease added into that parliamentary committee. And currently what we do is that we actually go and build the capacity of these parliamentarians within that committee, and trying to actually empower them to understand what are the regulations and what are for example, the WHO best buys, and what is the rate of return and how do we go about. And actually they are the ones basically who then try to see how it can be translated into policies on legislations. we did a desk review of all the non-communicable disease legislations in the country, and there are more than 86, out of which only about 15 have got regulations and laws, while the rest of them have just passed, but there is nothing done. Interestingly, 84% of them are outside the health sector. They are with the other ministries, so they have hardly been used. So what you are saying is very important, that you need to have that political push to make sure that these things can move.
Thank you.
Professor Bhima, could you ask a question?
Dr. Kaushik, thank you for the enlightening talk. I must say, in pediatric nephrology, I don't see complications of diabetic nephropathy because, it's something that occurs much later. But I just wanted to make a comment and then ask you a question. My comment is that, when I first started my training, we used to see almost exclusively type 1 diabetes in children. But the whole spectrum of disease is now changing. And we're starting to increasingly see type 2 diabetes in children. So my question is this something that you are seeing in your center as well? And have you ever seen diabetic nephropathy in less than 14-year-olds? Because I haven't.
Okay, interesting questions. One, I think, up to now, I've seen only 2 children with type 2 diabetes, presumably, and that was related purely to the obesity. And very, very early, I would say type 2 diabetes, mainly starting with impaired glucose tolerance, and then when they take a lot of carbohydrates and this thing going into diabetes and subsequently turn into diabetes. So only 2 children in my career with this one. So we are now, that means that we will be seeing them soon, but up to now, I think it's very rare. Unfortunately, in our situation, we also have this, what we call as maturity onset diabetes of the young, because if you look at our type 1 diabetes peak, and if you look at our registry, you find that most of these patients with type 1 diabetes actually are at the peak. Peak is between around 18 to 21 years. Sometimes in some region, it is 14 to 18 years. So you find that by the time they are diagnosed and they come into the system, then it's 14 to 18 years. We are seeing those whom we started in the program, because we have currently a program for type 1 diabetes children, and we have more than 3,800 children on the program. And you find that now those who were diagnosed 10 years ago, some of them now are we are starting to see proteinuria and very early renal dysfunction in them and a reduced EGFR, but very few of them are there currently. So we are not sure whether these are the survivors or what is happening, but something which we are now developing with the registry, and probably within the next 2-3 years, we'll be able to give you some definitive data.
Thank you very much for that. I must say, I have not seen diabetic nephropathy in a child less than 14 years. And at one stage, we did a little study where we looked at, SDS-PAGE, sodium dodecyl sulfate polyacrylamide gel electrophoresis, which is a very, very refined test for looking for, proteinuria, different types. And every one of them that we screened over 50 came back as 0. But with the type 2 diabetes, it's always, we are seeing it in the slightly older child, the adolescent with obesity. And that's becoming a major pandemic now. Obesity is becoming more prevalent than HIV, and we are seeing it because most of our kids are now starting to eat a lot of fast foods, and that's becoming a big problem in our country. But thank you very much. I really appreciate it.
Thank you very much, Professor Bhima.
Amar, with your permission, in the chat box, I have
Yes.
2 questions. If you allow me to answer them.
Yes, please. Yes, please.
Yeah. So one question is: will the screening in lower community health? Yeah. Will the screening in lower community health centers be sustainable, giving financial constraints? And if you diagnose, will treatment be provided free? I think it's very difficult for me to answer this question. I think it's a question of the local community and local health system, depending on which country you are talking about, looking at whether it is cheaper to screen these people and get them into the health system much, much earlier, or to wait for them to get the complication and then come into the health system, whereby it will cost 10 times more managing these patients. So I think it is something which will change from country to country, from councils to councils. So I think it is something for the policymakers and the health system to decide, which makes better economic sense. Regarding specifically age more than 35 in low and middle income countries, I think what we are saying based on the risk score and based on what has been the data available in the region. That is the cutoff point we have put in. But there is also, as I said, MODY, which sometimes in young adults between 20 and 35 years of age also comes in, but there you have a different presentation. So that was the reason for the cutoff of 35. Thank you.
Thank you very much, Dr. Akrabi, for those questions. We'll just take one more question from Dr. Azel from Arusha before we wrap up, Prof. I hope that's okay. Dr. Azel, I've unmuted you. Can you please ask your question live?
Okay, thank you, Dr. I thank you, Dr. Professor Kaushik. This was very enlightening presentation. So one of my questions would have been already asked, but I had a question, one idea. You said maybe if we adopt the HIV or TB model that have been successful, I have seen, for example, there are people who are HIV champion, or some of them are tuberculosis champion, people who have been suffering from HIV and then now are doing fine, and then these people are being used to educate others. So is this something that you're also trying to do in the model that you're applying to Tanzania? For example, you have patients who are maybe type 1 who are still in school. If this can be utilized to educate others, is this something that you are also looking at?
I think what we are doing is that there are three things. One is this study which we recently did with and it's going to be published in Lancet within the next 2 weeks or so, where we looked at the integrated model, because one of the biggest concerns of people in the HIV world was that when you start managing diabetes and hypertension in HIV clinics, you are going to compromise care for people with HIV. So their biggest concern was that will the viral load remain undetectable? And what we have shown is that over the last 2 years, 2.5 years, these patients, when they're diagnosed in HIV clinic with diabetes and hypertension, they have basically, it does not affect the viral load, and you can manage them. Their retention is much better. Their control is much better because there's an excellent recall system in HIV clinics. So you find that the quality of care is better, their recall is better, adherence is better, and their controls are better. And most important, it has been shown that it is actually, it is cost effective in a sense that by managing this multimorbidity in one clinic, you are having a net cost saving of about $180 to $210 per person per year. So that is a huge cost saving which you are seeing. So there it is definitely, that model seems to be working. Second thing is that peer, what you are talking about is the peer educators. If you can train people with diabetes or hypertension who are expert patients and who are willing to talk, because when a patient talks to another colleague of his, a patient, they understand the language better, and it is shown to be that the peer education has been shown to be much better approach in chronic disease. And that is the reason why you find that we are doing the peer training and trying to see whether the community health worker model will work better or the peer educator model will work better. But we suspect that the peer educators, if adequately trained and empowered, that might work much, much better like it did in HIV world.
Thank you so much, Professor. Thank you.
Thank you so much, Dr. Azel, for your question. And thank you so much, Professor Kaushik, for taking time out from your busy schedule to be with us this evening. We understand that you do have a heavy clinic waiting for you outside. Just one last comment from my end is that all the attendees from Kenya and Tanzania claiming CPD points, the link for the questionnaire for the points is on the chat box. Please do use that to claim your points this evening. And I would just like to invite Dr. Lloyd for the closing remarks. Dr. Lloyd.
Thank you, Dr. Kaushik, for this excellent presentation. And I think there's so much to look into. It will be on YouTube for everyone else, all of us, to actually go through this in detail. I think there's so much of literature that you've put on board, and extremely grateful for taking time off. I know today your clinic will go up to 11 p.m. and grateful once again for this wonderful session. Thank you so much.
Thank you for giving me the opportunity. And unfortunately, the data of complication is plenty. I could not present the real data, but I think what we wanted to focus is that for the region, prevention is the buzzword.
Thank you so much. Thank you very, very much.